Yeah.
Good morning. We're going to go ahead and get started. Welcome to the Indiana Commission to Combat Drug Abuse. This is actually our final meeting of the Commission, and our next meeting we will be meeting as the Indiana Commission to Combat Substance Use Disorder. That's a result of legislation from Senator Yoder from this last session. So with that, our first, we got a seat over here for you with Bernice's name on it. So with that, I'll introduce our recovery speaker, Phil Stuckey, who is also the executive director of our RCO, our hub down in Scott County, Thrive, and he's going to talk about not just his pathway to recovery, but also the work that they're doing at Thrive and Holding Space. I was able to go meet them and visit the location last month, and I'm really excited about the co-location and all the different services they're offering. So with that, Phil, I'll let you take it from there.
Hey, good morning, actually, to everybody. First off, thank you all for your all's time today and letting me come up here. Boyhood dream to be able to come up here and talk to you all and have this conversation. I would like to ask, first off, who do I get with to validate my parking? We'll get it afterwards. That's fine. That's fine. I do want to give you a little bit of a personal story, not to stay too much on that, because I'm really excited about the stuff that we're actually doing now, the solution piece of it. I grew up in Clark County, Indiana, down there by the Louisville area, and I broke my neck when I was 16 years old. When I was 16 years old, instead of doing surgery, because at such a young age, they thought my bones could heal back better. If they didn't do the surgeries and put the rods in, they started me on an opioid prescription. Fast forward a few years later, as you can tell, my tolerance and everything went up, so my opioid prescriptions went up as well. In 2004, I actually joined the New Albany Police Department, and I was a police officer for about 5 years there. The last 2 years, I helped the majority of with the flex team they had, which kind of did all their undercover narcotics and street dealing cases. I left the police department in 2009, still with taking my prescriptions legally the way I was supposed to. And then around in 2011, I noticed that I started becoming really addicted. I actually left my doctor's office, and within 2 weeks, I was about 100 pills short of my count in a 4-week period. So I went back to my doctor's office. At the time, my wife was a nurse, and I went back to my doctor's office and told him that I was very addicted to these. And they put me on something called a fentanyl patch. And it took me about 1 month to figure out how to abuse a fentanyl patch. After that, it pretty much, and I believe, let me just stop and say this real quick. I do believe that my doctor at the time did the best she could and really gave me the best care that she thought I needed. It was just a circumstance of the things that happened. It was about 6 months, 7 months into that. It was unable to find my prescriptions anymore, but I'm off the streets anymore. And as you can tell, I mean, I told you I was a police officer for 5 years. It wasn't my moral decisions to actually make illicit purchases for illegal narcotics. If I didn't purchase these things, I couldn't get out of bed in the morning. I couldn't take care of my children anymore. What I thought I was doing was taking care of my children. That didn't last too long, and actually the only thing I could get to feel better was heroin. And it wasn't that big of a decision to move to heroin, because it was just, I need something to get up and to feel better, and that's the only thing that was available. After becoming homeless for about 2 years, my house got foreclosed on, lost the cars, lost the bank accounts, lost the wife and the children, 3 DCS cases. I picked up over 16 convicted felonies, 5 misdemeanors. I've overdosed 3 different times and been brought back to life. I've been in treatment over 12 different times in inpatient stay. Luckily, the seed was planted in some of those initial stays where somebody told me that they believed in me and I could get over this. Long story short, everybody asked me, Phil, what's the turning point? What made that decision stick? I will be honest with you, if I knew what that was, I would have bottled it, trademarked it, and it'd be sold in the Walmarts all across America. I don't know. I believe it was some kind of spiritual awakening inside me that happened and some kind of connection that got me together that actually let me choose a different pathway. First off, I will tell you, it was an inpatient stay that got me abstinence to be able to make that decision. Because every time I was locked up or I went into incarceration, being a former law enforcement officer, you're in segregation. So that means I was in the suicide pad, which eye contact is every 30 minutes, even if you want to sleep or not, and the lights don't get turned off. So if you can imagine someone going through detox while at the same time not able to actually detox, as soon as I could get out, I went right back to the same decisions that I made before. With that being said, November 14th, 2014, is the first day of my recovery from abstinence, and I've been abstinence ever since. Since then, some of the things that we've got started, and if you all haven't heard, in 2015, there was an HIV epidemic in Scott County. It was the largest HIV epidemic per population in the world. We had everybody from the BBC come across I call it the pond now because that's what they call it, come across the pond and do stories. We had we had a lot of help from our state leaders up here as well that came down. And so with that, one of the things that happened is our community got together, our local LCCs got together, and they tried to form, what are we missing in this county? And so they started asking some of the people that were in recovery to come aboard and figure out how we can get a handle. Because as you can tell, or if you haven't heard, the epidemic was actually fueled by drug addiction and the sharing of needles. And so when we found that out and we knew that there was an issue there, we came together. Thrive was born and started being implemented in 2017. We signed off on our bylaws in 2018, and we are a recovery community organization. We had an amazing people come down from the state level. Always have to give reverence to Tom Cox, who came down to help us get that RCO started in the Indiana Recovery Network. Since then, in 2020, maybe you've heard of another epidemic called COVID. Everything we were doing was changed. We were 100% of voluntary services for the RCO. So that meant we had about 15 recovery coaches that were all state certified. And so after they worked their full-time job, they would then become volunteer recovery coaches and help people in the community. When COVID happened in 2020, thanks to the Indiana Recovery Network, DMHA, FSSA, and Indiana Next Level Recovery, you all came up with something called the Regional Recovery Hub. We were chosen to be one of those initial 5 hubs. We were actually the anchor hub for the Southeast region. So that means we oversee 21 counties in the state of Indiana for community-based recovery coaching, all free services. Since then, we have hired we found some other fundings. We've hired an additional 4 full-time staff. So now we actually have staff. We have programs in place. We have things from overdose response team. So we have people on call 24/7. So if a first responder goes out from police officer to EMS and someone says they need help, they'll call one of our coaches and we'll come to the scene if it's cleared, or we'll go to the hospital and meet them to start talking with that individual. We believe that they say the window is 15 to 45 minutes for someone who reaches out for help. My belief, it's the next call. And what I mean by that is if we don't answer our call, but the dealer does, whoever they get to first is going to help them. We also have we're in 4 different jails at this time throughout the Southeast region, where we go in and we run groups with them, and we also start the reentry process, which means application for housing, application for medication if they so wish when they come out, or even application for outpatient programming. We also have a program that we work with our inpatient facilities where we'll actually go in, our recovery coaches will meet the participants face to face, and so that way when they're discharged from their outpatient, they already have a sober companion that's going back to the county that they know of. So they already have one person they know is in recovery in their county. We actually also help people find and go to meetings if they would like a peer support meeting of any kind. Our coaches will actually go to those meetings with you. I think we all can agree that, this disease is an isolating disease. So the antidote is some kind of connection. And so if we can start that connection with our coaches and then back into society, we get the recidivism off that seems to be great. I'm also very happy to say in June, we are going to start a program, thanks to DMHA, special thanks to Becky Buhner, called the IRACS. The IRACS is, and I wrote it down because it's, how they do acronyms around here. It is the Indiana Reentry and Correctional Support Program. So what that means is we're going to place 4 full-time peer recovery coach, and we're going to pilot it in the Scott County Jail, where at any time, whether if they're going back to DOC, if they're in long-term, say they're fighting their case or don't know what's going on with their case, if they're people with 90 days or less, or even if they're just weekend stays and they bond out by Monday, they're going to have an interaction with one of our peer recovery coaches. I think that's an amazing piece that we're being able to get a part of. And once again, I want to say thank you to DMHA. Another thing that we have done, advocacy-wise, I told you all about that 2015 outbreak. With that 2015 outbreak, if you all remember correctly, at that time it was Governor Pence signed into law the first ever syringe service program in the state of Indiana. Unfortunately, the commissioners in Scott County, as of June of last year, decided that December 31st would be the last time that those doors would be open. I do want to introduce somebody real quick that I want to bring up, if you don't mind. This is Kelly Hans. She's our program manager, and she's also the director of a thing called Holding Space Recovery Project. Together, we have actually partnered in the same facility where you have the RCO on one side, and you'll have the as of now, the non-syringe harm reduction program on the other side. So people come in just in the very beginnings, to build that relationship, build that trust, and then we have recovery coaches that can come over and assist as well. And I'll let Kelly talk a little bit about some of the stuff that we encountered with that as well.
I'm Kelly Hans. I am also a person in long-term recovery, and back in June, when the commissioners made the decision to close our county SSP, there was a lot of work to figure out how we could get another one up and going. And in the law, you can go through a municipality to get it approved. So I created a nonprofit. With it going through a municipality, a county health department couldn't operate. So I created a nonprofit to take on a new SSP, and I have been in front of Austin City Council so far, and we are working on next steps to have a legal syringe service program up and going within Austin city limits at this time. Like Phil said, we are in a building together. Holding Space is on one side, Thrive is on the other. So people can come in right now for non-syringe harm reduction services. They still have access to naloxone. We actually have a nalox box outside our door, so they have 24 hours, 7 days a week access to naloxone. Harm reduction is that's a huge first step for people to come into recovery. You build that rapport with somebody when they come in. They might not even know what they want, or they might not ever see themselves doing anything other than using for the rest of their life, but it's that contact that you get with them and those conversations, and hopefully you can get them into recovery, whatever that looks like for them. So right now, like I said, we can offer everything but syringes. We offer HIV and Hep C testing. We have a food pantry and a clothes closet to try to get people to come in more. And that's what we do. And as they come in and ask for help, I myself am a certified peer recovery coach, but if they want more services, I can refer them right over to Thrive. We can walk down a little hallway and I can get them connected to a peer recovery coach at that time. So keep praying for us in hopes that we get our SSP up and going in Austin soon.
Thank you. And one other thing I just want to touch on before I leave you all is another thing that we've done is we've partnered with a family practitioner. So we're actually able to do LARC, which is the long-acting contraceptive that they put into the arm free of charge for individuals that do not want to get pregnant and are still living in an active addiction lifestyle. Another thing that we have done is we partner with another provider if we need to do MAR, Medicaid-assisted recovery, that we can do it within 24 hours. We also take telepads out too, because you have to think one of the areas we cover, Scott County, is a very rural county. Broadband is not something that we have access to. So we actually bought some telehealth machines for our coaches, and if they have appointments, we'll go to their house, give them headphones, put them in a HIPAA-compliant environment, and let them do their appointments. We also set up a telehealth machine in our office to do the same thing. And then the last thing we also did, we partnered with an LCSW. In the southeast region, which I know all over Indiana, I believe the last number I heard was 7,000 shortage of clinical employees. We're filling that as well in the southeast region. So what we have done is we partnered with an LCSW, who actually right now our outpatient services are about 4 to 6 weeks out. So if you walk in and ask for help, they tell you to come back in 4 weeks. So we partnered with our local CMHC and a local LCSW to where we're going to do gap services. We have an LCSW that's going to see them for at least that period of time until they go back. We'll put them with a therapist and a recovery coach until they go back to that CMHC. With that being said, there is one thing I want to leave you all with today. You know, amazing work that's happened at the state level. One more thing I want to tell you. Thanks to the governor's office, DMHA, and FSSA, we were able to put the first ever Narcan vending machine in a hospital emergency department in Clark County. We're very happy about that. We refill that thing on a weekly basis, and that holds over 360 doses. And the one thing I wanted to leave you with, especially because, you know, our belief is that recovery is harm reduction and harm reduction is recovery, is something from Bishop Desmond Tutu. There comes a point where we need to stop pulling people out of the river. We need to go upstream and find out where they're falling in. So thank you so much.
Well, thank you, Phil and Kelly, and I would encourage any of the members of the commission, as you're driving through that part of the state, stop by, see them, the work they're doing, and just how they have, they're working in their community and how they think about the work that they're doing. It's just really refreshing to go down there and see a group that's working together. That is, it's just really exciting. If I could go down there every time I get kind of down about the work we're doing sometimes, they've got stories of how they're helping people and stories of how they're bringing the community together. I can't say enough about the work that you guys are doing, so thank you. Next up, Jim Gavin, the Communications Director at the Family and Social Services Administration, is going to provide us an update on the Know the Facts campaign.
Yes, and thank you very much for the opportunity to do so. Hopefully people recognize the title, Know the Facts. It's something we've been working on for quite a long time. It's a campaign, but it's also a discussion. And it's a discussion I know that many of you have participated in about addiction. We've been having it across the state for 5 years now. We've tried to center this discussion around 3 main points. Addiction is a disease, there is treatment available, and recovery is possible. Through this discussion, Know the Facts seeks to educate and build empathy among Hoosiers so that as a state and as a community, we can fight the stigma around addiction that has traditionally been a barrier to treatment for so many. And that's a main point. Again, treatment is available. It's more available today than it was when we started. It's more accessible now than it was when we began our campaign. Jay Chaudhry is going to be updating you on the current work of DMHA after I'm finished, and Phil already talked about some of the work of DMHA that's touching him and his work down south. So that was very good to hear. As far as the campaign goes, as that treatment was going to be increasing, and as we started having these conversations about how could we reduce stigma and how could we help, really, we wanted to support the access to treatment, because when the conversation would turn to treatment, we wanted to eliminate any stigma that might be happening to prevent people from pursuing that treatment within homes, communities, work groups, and very importantly, even within one's own mind. We know that as self-stigma. We endeavor to replace those thoughts with thoughts of hope, empathy, and compassion, because through this Know the Facts campaign, more Hoosiers will know what's possible when it comes to recovery. Along the way, we have met, and I'm showing the one slide of our website here, we've met several heroes of recovery. I consider them to be the heroes of recovery. And they've very proudly and willfully sat in front of our cameras and told their stories to us, and those stories become focal points of the campaign. And again, you can go to knowthefactsindiana.org and watch those stories. They're stories of real Hoosiers and their successes in recovery. They're also featured, as you can see, throughout our campaign in places like outdoor advertising, television advertising, social media, and the like. We did have to make some adjustments to the campaign to account for the pandemic. So that is why, for example, you'll see that many of the stories feature animation. We were just about ready to go out and shoot a lot of video with a lot of people and their families, and that became something that was ill-advised, and so we didn't want to stop the campaign, and so the current theme of the campaign creatively does feature some animation that links back to the stories that you see on our website. I'm excited actually to play for you the most recent story. This is a story not only of one of our heroes of recovery, Lindsay, but her family, and it's a very, very real story. It does start with tragedy, but it becomes a story, again, of those thoughts and emotions that we all want all Hoosiers to have when it comes to substance use disorder and recovery: hope, empathy, and compassion. I think it's a very powerful family story, and I hope you agree, and I also hope that I'm successful in getting it to play.
Nick was 13.
Nick was 13, walking home from school, beautiful town, pretty day. Somebody offered him LSD. I don't believe Nick was ever sober another day of his life until he died 10 years later at the age of 23.
My brother Nick was the most free-spirited person I have ever met. It was hard on all of us to lose him.
Lindsay didn't know how to cope with those feelings. I wish I had known more about what was troubling her.
Lindsay wanted to try the things that Nick had done so she could understand them.
What was so great that he literally gave up everything, everything.
I can look at all these things that we went through and I'm like, I get it. I know why you felt that you needed a release.
It progressed really quickly from there. It went from alcohol and marijuana to party drugs like ecstasy and mushrooms, and then from cocaine to heroin.
She was not the same person, not even close.
I got to the point with both Nick and Lindsay just by saying hello, what's going on, and how you doing. I could tell if they were using or not. A parent just knows their child.
Drugs are changing the person's brain chemistry, so their behavior changes.
Love the child and hate the disease. When you're in the middle of it, it's hard to separate, but love the child.
My boyfriend at the time was moving to Evansville to go to college. The hope with Evansville was a new place, and for about a year, everything was really good. We bought this little single-wide trailer, we gutted it, we painted, and we made it our own, and we loved it. Like, that little trailer was our home, and it was the first time in my life that I had something that felt really good to me. What I didn't recognize was that I'm gonna take me with me wherever I go. It was a different city, it was different drugs, and it was different people, but it was the same result. I asked my boyfriend at the time to move out, and I let a guy that was cooking meth move into our trailer. Everything that I had built up, a home, a job, all of that, it all ended. And for about 30 days, I just stayed high. I didn't eat, I didn't sleep. In active addiction, it's like, it's a dark place to be. You don't know how to get out of it. alone and scared and frustrated and angry and sad, like all at the same time. I ended up having a drug-induced seizure and was placed on life support.
And we didn't know she was gonna make it or not.
Even if you knew it was coming in a way, it doesn't make it easier to face that.
I mean, I knew rationally that it could happen. Not emotionally. Couldn't happen.
My mom called and said, we have to go right now, and this is it, you know, we have to go and say goodbye.
But I do remember when I came back to, and I heard my mom and my sister's voices for the first time, and a wave of relief washed over me.
Even when you feel hopeless, there's still always this like string almost, and you gotta kind of hold on to that string. And I think my mom is really great for making you hold on to that string no matter what.
Don't give up hope. Just don't.
I
I believed in her.
It took Lindsay deciding herself.
I finally got to a place where I was like, using drugs isn't working, killing myself isn't working. Like, I need to try and do something, try and live my life in a different way. I was meeting with my psychiatrist, taking all my medications as prescribed. Like, I was sticking to the things that I was told would really help me maintain healthy recovery. One of the people that I was working with was a peer recovery coach, and she came to me and she said, Lindsay, you could do what I do and you could be really good at it. And I was able to take the test and I passed and I was certified, and I was like, oh my God. And I'm like on the opposite side of things now. Like, I never thought that I would get there. And my whole job is sitting down with people like me and saying, I know what you're going through because I've been there. What can I do to help you get better?
I'm so proud of Lindsay.
Even being here to look back is a miracle.
It's not that way for everybody, but I'm just grateful that we were able to get through it.
I feel amazing being with each of my family members because I almost wasn't.
And Nick's an important part of this story.
We all love him and we all miss him. After I had about 4 years of sobriety, my boyfriend reached out to me and he said he needed closure on our relationship. And I said, let me do that for you. And so we got together and we talked, and we got together and we talked again, and we got together and we talked again, and we've been married for a year now. He is my biggest support.
I think Lindsay and Mike are best friends taking on the world as a team.
And she continues now to help other people who have an addiction problem. And I'm very proud of her for that.
I like to be a pillar of hope. I like to help other people know that recovery is possible and that it is a beautiful journey.
Thank you for your attention to that video. The next slide I'm showing shows kind of life for the campaign post-COVID. Several community events that we've been able to participate in lately as we're making a concerted effort to take the Know the Facts campaign out on the road. The upper left photo is in Muncie for an event with Ball State. Upper right is a Recovery Month event that took place right here in downtown Indianapolis, the purpling of the canal for Recovery Month. And the lower part of the screen was our recent trip to Fort Wayne for a community conversation hosted by the Fort Wayne Recovery Cafe. It is challenging to measure stigma. We talked about that quite a bit at the beginning of the campaign. Challenging to measure the results of a campaign because of how nebulous a concept stigma can be. But we have, we think, found a way to conduct some ongoing research. So we've conducted some research panels 3 of the past 4 years so that we can track our data. The latest just took place in March of this year. There's some indication, I believe, that stigma is reducing throughout Indiana. For example, our survey indicates, and this is the graph that's on the lower left, that there is a 12-point increase over the last 3 survey cycles in agreement with the statement that private and public insurance should pay a significant portion of treatment costs associated with substance use disorders. And this likely indicates that Hoosiers are increasingly supportive of treatment and recovery resources, which helps remove one of the barriers that we've talked about that people may face. Another encouraging comparison can be made when we compare the survey that we do to a national research project that was recently commissioned by the group Shatterproof. By the way, we're very impressed with this Shatterproof group. You might want to look them up. The research that they did was nationwide. It was actually designed by some Indiana University researchers. It involved a sample of nearly 8,000 U.S. residents, and their research concluded that nationwide, over 75% of the public do not believe, unfortunately, that a person with a substance use disorder is experiencing a chronic medical illness like diabetes, arthritis, or heart disease. Our research panel, we asked the question, substance use disorder should be treated the same as people with a chronic illness like heart disease or diabetes. We asked people what their level of agreement with that statement is, and 58% of Hoosiers that we have in our panel strongly or somewhat agree. So while the research methodologies are different, it does appear to be a fairly significant difference in how Hoosiers are answering a very similar question to how that question is being answered nationwide. We at least take some hope from that. Know the Facts is currently scheduled to continue through this federal fiscal year with some special emphasis on communities of color, both from a community outreach perspective and a targeted media strategy. While there have been increases in recent years in the number of Hoosiers seeking treatment, those increases are not as evident among minority communities, particularly among Black Hoosiers, and that is why Know the Facts will be embarking this year on a special project to target Indiana residents who are Black or from other minority groups, and specifically will address subject matter that may be causing wariness about receiving treatment. Again, we believe that Know the Facts is a continuing conversation, and we need to be including everyone in that conversation. So we're just getting this project underway, and we'll be seeking a high level of community engagement in designing that project. We certainly, lastly, this is a very quick call to action. We certainly appreciate any of your continued engagement. Doug, Shelby, Ethan, thank you very much for all the social media work that we see you do. All of the organizations that are represented on the commission, we would certainly like you to help us through your social media channels and by going to knowthefactsindiana.org and promoting the content that we have there. Again, thank you very much for the opportunity to update you on our campaign.
Thanks, Jim. Are there questions for Jim? All right, thank you. I'm going to jump back up to the first order of business. I forgot to approve the minutes when we started, so I'll entertain a motion to approve the minutes. And second? Second, perfect. All in favor? Aye. Thank you, minutes are approved. Next, Jay, thanks for joining us. Jay's going to give us an update on the work at the Division of Mental Health and Addiction.
Thanks, Doug, and Shelby told me to sit here, so I'm not snubbing y'all by not getting up. So I listen to Shelby whenever she talks. So Jay Chaudhry, I'm the director of the Division of Mental Health and Addiction, and I'm here both as a proxy for Dr. Rosiniak. He sends his regrets, and here to present as the director of the DMHA. So this next slide, I'm going to warn you, it's really painful to look at, and that's intentional. Because I've recently become aware of a public policy term called a wicked problem. Several of you may have heard of a wicked problem. That's not meant to be evil, not a normative judgment, but wicked means it's so complex and interdependent and related to other huge problems and driven by other huge problems that wrapping your head and mind and heart and arms around it is a real challenge. And so what we have here is, the reason why I've pretty much had a headache nonstop since September 2019 when I took this role and was tasked with kind of wrapping my head around the behavioral health treatment system and what we can do to make it better. And I think the conclusion is that, you know, this system and working with this system and fixing this system is in fact a wicked problem, right? It's one of those things that all these different things, you know, poverty and trauma and political issues and workforce and social media and you know, issues like, you know, bodily autonomy versus forced treatment, right? We have reasonable debates about, you know, what's the appropriate role of public safety in this, and these are all kind of interdependent on their own specific issues. And then you add that on top of all these different areas where folks receive treatment, and all these areas are siloed and fragmented and chaotic. They're hard to navigate for both patients and providers. And so, you know, wrapping our arms around this is you know, wicked problems require wicked solutions. And so, you know, we were given an opportunity, or in the midst of an opportunity, due to the various COVID response legislation from the federal level, you know, to be the stewards of and be responsible for, you know, a fairly significant amount of one-time funding, right? So the sources are up here, and so I don't need to go into all of the different sources. I would want to thank our legislators for the HEA 1001 appropriation, you know, and so we have a challenge and opportunity, right? The challenge is, you know, the thing about wicked problems is you can't really pull one lever or two levers or add or subtract or look at any particular part of the system, because it's bound to have unintended consequences somewhere else. And so our challenge really continues to be, we're about a quarter of the way through this, is, you know, how do we take this one-time infusion of funding? And the key is it's one time, right? This is not ongoing. This is not an ongoing appropriation. This is not money that we have any reason to think will repeat itself. And so how do we take this one-time infusion of capital, right, and use it to attack and make progress towards solving a particularly wicked problem? So, and feel free to interrupt if you have any questions or anything. And I just wanted to put a plug in. You're going to hear about the opioid settlement, I believe, later today, and that's something we're keeping in the back of our minds as we think about how to attack these problems. So here's what we've kind of come up with, four different buckets. We think all of these sufficiently address and are responsive to the complexity of the issue. And we'll talk about all these in turn. So, you know, sustainable structures, I think ultimately, you know, the solution to, or at least a solution to really complicated problems is to build structures that will help you navigate those issues. And we'll hear about a couple of those. And then, you know, the quality of our systems, and so again, we'll get into all these, and access to services, and then workforce issues, which again, we all hear about, we all know is an issue. It's also one that is really difficult to do anything in the short term about. So sustainable structures, and we'll talk about a couple of these more a little bit later, but you heard about 988, I believe, at the last meeting. I'm gonna touch on that again because we believe in repetition, and you know, it's a really important thing that everybody needs to know about. CCBHC, which we'll talk about. Criminal justice, unfortunately, as this commission knows all too well, the criminal justice system is, you know, in some ways the single biggest entry point into the behavioral health care system, and so we need to figure out a way to wrap our arms around that and take advantage of that existing structure and system, you know, to get Hoosiers better health care or better care. And then you heard from Phil, and I just want to, you know, make it really clear to say that they're making miracles happen down in Southeast Indiana through Thrive, and we're, you know, honored and thrilled to support them, and they're part of a bigger infrastructure called the Regional Recovery Hub, or Indiana Recovery Network, or Regional Recovery Hubs. And so we hope to bring organizations like Thrive to every single part of the state. Unfortunately, we don't have a Phil in every part of the state, but access to services, and so we have a couple grant programs that are currently active, so I can't talk a ton about them, but the Community Catalyst Grant is a large open-ended grant application for communities and local organizations to apply for. We got an unprecedented level of interest in this program. People that have been at the state for 20, 30 years told us that they have never seen this volume of applications, which on one hand is a lot more work, but on the other hand is really, really great because, we're currently trying to figure out how to sort through all that and make the best awards for the state. We're also really excited about this other program called the Accelerator. There's lots of folks, who were Phil Stuckey 5 years ago, had a mission and a dream and a plan, but may not have had the infrastructure or the time or the level of experience to really turn into what Thrive is today. And so we've created what we're calling the Grassroots Accelerator Program to kind of adopt some of these folks, put them through like a organizational boot camp of sorts, and turn them into an organization that's really capable of serving the community. And then a whole host of different programming and prevention, intervention, and treatment. We're really trying to take what we're considering like investment mentality here. We're trying to target folks and measure outcomes and measure success and find things that can be scaled. And so, a couple of those to hit on. There's a program called multisystemic therapy, or MST, which is a treatment modality where high-risk youth are given kind of family wraparound services, and really the whole family is brought into the treatment, and it's something that's shown great promise in its limited use other places, and so we're excited to bring it here and hope to measure the outcomes and show folks like Chris Johnston that this was a good use of money, and so maybe we can continue to invest in these things. So again, quality systems, this is really about the sort of connective tissue, right? There's a lot of problems on the back end, whether it's our data systems or the way some of our financial structures are set up or administrative code. And so we know that by spending a little bit of money now to fix these, that will serve as a multiplier and will resonate far beyond whenever this money's gone. And so, we're excited about that, and I think we'll have a lot of good, sustainable changes that will result from this. And then finally, workforce. This is the trickiest one. This is one where there is really no short-term solution because we're all kind of drawing from the same pool, and we know that there aren't enough people to do this work. One of the concrete things we've done here is we're funding a whole host of psychiatric residencies and fellowships and internship programs because we know that psychiatrists in particular serve as a multiplier, right? You can build an entire treatment team around a psychiatrist. And so we're excited about that, and there's some other things in the works that we hope to be able to talk about soon. So I wanted to talk real quickly about a couple of those sustainable structures. So again, Dr. Drapeau, who's here, kind of lurking in the back there, was here presenting last time, and he went into great detail about 988. So I won't really go into it as much, but by way of recap, 988 is going to be the new 3-digit number for behavioral health care response. And so we're treating it as more than just a suicide prevention hotline. We're treating it as an opportunity to build an entirely new system of crisis care, right? A sustainable structure that will be accessible, available, and serve folks well into the future. We're trying to be as forward-thinking as we possibly can in a system that's built on biennium budgets, and so we're looking over the next 5 to 10 years to build this. And so, based on 3 pillars: someone to call, someone to respond, and a place to go. So our first kind of laser focus right now is on that somewhere to call. We'll be available to receive, our system will be available to receive these calls in July of 2022. And I can say, by having been in national meetings and national groups around this thing, that I'm very proud of where we are as a state in terms of our preparation for 988. And I think that folks are starting to take notice, and we've been asked, Dr. Drapeau has been asked, I've been asked to speak at several national meetings about the things that we're doing here. And then ultimately this is the goal, right? And so this is something that should be very familiar to many of you. Right now, the only real place for folks with behavioral health crises to end up is the emergency room or jail. And we're looking to build a system that diverts folks away from that. And so again, this is over the period of 5, 10, 15 years. This is not going to be done overnight, but we're really excited and really grateful for the opportunity for this one-time funding to start building there.
Jay, can you read us what that footnote says? I can't read it. It's got a citation in it, and I can't read it either.
Yeah, so this is, the citation is from this woman, Dr. Margie Balfour, who was responsible for the Arizona crisis model, which is kind of considered the best one in the country. And so this, it's a site for her paper.
So the least restrictive, least costly is not a function of the Families First Act requirements?
No, this is completely separate from that. This is more that it's less restrictive and less costly to I think Phil mentioned the upstream philosophy. This is really, this is the way to take it upstream, right?
Jay, was there funding tied to that federal legislation?
Great question, Doug. So there was not any funding tied to the legislation. However, states are authorized as part of that legislation to implement a surcharge on cell phone bills, similar to the way that 911 is funded. And so far, I believe 5 states have taken advantage of that opportunity. And so in Indiana, we have the fund set up thanks to legislation in the 2020 session, and we look forward to further discussions with our partners on that surcharge moving forward.
So to be clear, we would need to pass legislation through the legislature?
We would. I believe that the Indiana General Assembly, I believe, is what they're called, and I believe a couple of the members are here. And we look forward to those conversations. And I think what our promise to you all is that we will have a very clear plan for you all about what this potential funding could be used for, but this could be transformative. Again, you think about sustainability, you think about a period of 5, 10, 15, 20 years. We're really excited about that promise of the surcharge. So of course, 988 addresses a very important part of the system, but it is only one part of the system, and we also know that the underlying mental health care system, or the safety net, is one that it's not necessarily functioning to its optimal level to meet the needs of Hoosiers. Now, there's great work happening in various parts of the system. We can't forget that, and folks are doing, making miracles with systems that are not necessarily designed or set up to support them. So I got an email a couple days ago from a sheriff who in the subject line was, here's an example of how nobody will help our folks. And I think that, again, he wasn't wrong, but I think the reframe is, here's an example of how the system is not set up to allow these people to help our folks. And so what we're doing, and right now this is, again, a longer range process, there's a federal treatment model called the Certified Community Behavioral Health Clinic, which is kind of the next iteration of a very old and creaky community mental health center model, which was designed in the 60s and built in Indiana over the 70s and 80s. And so this is bringing, new healthcare concepts like value-based purchasing and prospective payment rates to the behavioral healthcare space, and will allow us hopefully to open up this system to folks that want to help. And so, again, we're in the very beginning stages of this. Our only deadline right now is, thanks to House Enrolled Act 1222, which for the record was our agency bill, we put an obligation upon ourselves to submit a plan for this transition to the General Assembly by November 1st. So we look forward to making that plan and having further discussions about that. But I wanted to flag it because you all will be hearing a lot more about this over the next several years. And this is a model that we think is sustainable long-term if we do it right. Yeah, Chris.
Yeah, thanks, Jay. Quick question. It looks like there's going to be a report due in November about the CCBHCs. Is it safe to assume that in that report it will talk about like how many CCBHCs to provide coverage for 7 million Hoosiers and what the true cost of that would be?
Absolutely. We're going to do some pretty intensive financial modeling, and I think that's ultimately we have to understand that to understand anything else. Thanks. And so most of you should be familiar with this slide. This is the sequential intercept model. This is, I think, a really helpful tool to understand a wicked problem because it deconstructs when folks intersect with the justice system. And so if we're talking about the 988 system, that sits there over at intercept 0 and 1, kind of in the community, and we think that this will be a really vital tool in that particular part of the system. But I also wanted to sort of leave you with an example of a program and intervention from a different part of that system here in between intercepts 2 and 3, and an example of a problem that is actually not a wicked problem, right? The opposite of a wicked problem is called a tame problem, which doesn't mean it's simple, it doesn't mean it's not complex, but it means that you can kind of wrap your head around it. And so We have an issue right now at our state psychiatric hospitals. Many of you are aware of it. It's a problem kind of across the board. We have a long wait list, takes a lot of time to get in there. There's a lot of reasons for this. COVID is not over in the hospital network, and it continues to be a problem. We have staffing issues like everybody else. There's an increase in referrals from the criminal justice system to the state psychiatric hospitals, and then, like we talked about, there's limited opportunities for diversion available throughout the system, and this is creating a lot of risks for our system. But because this is a tame problem, not a wicked problem, we do know some solutions here. And so, historically, folks who were committed to the hospitals from the criminal justice system only received care in the hospitals. What we're doing, again, is moving upstream, right? So we're going to provide care to them in other places, whether it's the jail or other inpatient settings, and we're also working towards community-based restoration. And so we did this in a very methodical way. We started with pilots, and those pilots showed about a 60% reduction in the time it takes for somebody to go through this process, as well as about a 2/3 reduction in costs for that process. And so we're really excited to use those pilot programs to learn and build new programs, as well as address other things within the hospitals. I think the hospital network, like a lot of the system, is an old network. It's an old system, and so we're kind of bringing 21st century healthcare innovations to the state psychiatric hospitals. We're working on some policy changes because this sits at the intersection of kind of criminal justice, mental health care, and all the rest, and there's some policies that need to be addressed as part of that. We think that 988 and justice diversion ultimately will help address this problem. And then because this is a tame problem and not a wicked problem, we have a tangible goal here, which is 4 months to 4 weeks. We hope to get that wait list down to 4 weeks by the beginning of state fiscal year 25. So, any questions?
Yeah, is 4 weeks short enough?
Well,
Seriously.
it's not, to answer your question, Dan.
We don't know the adverse outcomes of wait time.
Yeah.
I can tell you that it's catastrophic. It doesn't matter if it's a 1-day wait or a 6-month wait, unless the other parts of these things are operational in a slick way. So I'm retired, but every day I get a call. I got one yesterday from a grandfather. I want to talk to you from a grandfather in Corrigan seeking services in southeast Indiana and trying to find the pathway. So in December, the Surgeon General declared that pediatric mental health was a public health crisis, the definition of which is a matter requiring the, quote, the public's immediate attention, close quote. So here's my question, Jay. Yeah. So if you had to rank order what you're going to do, what can we do immediately? And so what's the order of priority? Is it the suicide hotline? It's clearly not the staffing, because that's a long-term issue. Is it the social services being available so an intervention can be done? I mean, what is it that we should do now?
Great question, Dan, and I wish I had an immediate answer for you. I would say the 988 hotline is something that exists now. We have a deadline, we have a structure, and I think it will make a big difference even in July, when all we can do is make sure all those calls are answered, right? And the thing we're doing in Indiana, which is, I think, unique to other states, is we're actually building our 988 platform on top of our 211 platform. So other states are scrambling, trying to figure out, well, how do we stand up a call center? They've never done it before. We've done it. We know how to do it. And they are a well-oiled machine after COVID. And so the reason that's relevant to your question is because a lot of times these behavioral health crises are not necessarily about behavioral health, right? They're about other social determinants. They're about, I'm hungry, I need a place to stay, and so by building 988 on top of 211, we hope to have that sort of seamless transition between those two. But to answer your question about the children, I mean, that's something we did put out an RFI, it's active right now, sort of for healthcare systems to answer the call, to kind of match our investment into immediate solutions to pediatric mental health. So we're looking forward to the responses to that, because it is a crisis. And I think that the other thing to touch on, and this is again more of a question, not really an answer, but one thing we're in uncharted territory right now as far as the state government in terms of historically our area, like our area of focus has been the folks that are seriously mentally ill and indigent, right? And now I think very appropriately we're being asked, well, what's your plan for the rest of us? What's your plan for the folks that emerged from COVID, with, worsened mood disorders, worsened symptomology? And I think that the truth is as a state, we cannot drive that response. Like, I'm a firm believer in the state. We can do a lot and do a lot well. I wouldn't be in my job if I wasn't. But one thing I think I wanted to mention is the Lieutenant Governor's Roundtable, which Dan, you're a member of, and so Lieutenant Governor Crouch has convened, and Doug is a member too, has convened a roundtable of folks like Dan from healthcare and the private sector, and I think that ultimately, like, we need to get together, and this is an all hands on deck situation. So a public health crisis is a call for an all hands on deck response, and so there's things we can do. I appreciate your question.
I also, I'll add, when we were talking about the CCBHC model, so I was up in South Bend yesterday and had met with Oaklawn, and they're one of our pilot sites for CCBHC implementation. And just this week, they started that immediate screening and access, and we had lunch with a judge in Elkhart and a couple other providers, and how that begins to change things for our criminal justice system. When a judge is ordering someone to probation, and then they can walk them across the street to the community mental health center office, and they have immediate access, whereas before, it's a 4-week wait, or it's even a 2-week wait is too long for that initial assessment. And the other changes that they've made, and I mean these aren't easy changes for our community mental health centers, but adding more groups so that they can handle the additional access, looking at the paperwork that people are doing. I mean, these are all things that
I can tell you what happens when there's an RFI that goes out. Unless you've got someone on your private company or 501c3 staff who can do it, nothing happens to it, because there just isn't the capacity. So the paperwork really did a value stream. You're an expert at that. What could you stop requiring?
Absolutely, and so an example of that is, though, an intake at the CMHC takes about 2 hours right now.
Well, I took my law school class to drug court.
Yeah.
Holy cow!
Yeah. Well, the other thing, Dan, you mentioned immediate. I don't think we've even begun to wrap our heads around the game changer that could be telehealth, right? Because ultimately, that's access that just wasn't possible, pre-2019, and so I think we've done a really good job here at the state of aligning our policy and statutes to take advantage of that. But I think that we need to move past it being just another tool in the toolkit and to actually being the sort of foundation for that toolkit.
So if I were king of the world, I would make telehealth number one on the priority, because we have the systems to do it, and some states are doing it. Baltimore's doing it as a local thing, for instance. So if we were to start someplace and open, then the question is, okay, then what? So I won't ask any more questions.
No, they're great questions. Thank you. Yeah. Yes, Representative Fleming.
Thank you. Thank you for your presentation. I see two opposites veering in different directions, because I see a public opinion about, or the opinion about public and private insurance decreasing, that we've gone from 59% in 2021 to 33% in or 2020 to 2021. So while the public is saying maybe we're just kind of had it with this, why is so much of our money going here? We see increasing need, and we saw with the pandemic, with the cost of living going up, all of these wicked problems that are exacerbating this problem. So we have some funding, but much of it is limited, much of it is short-term funding. How are we going to sell to the public that we have programs here? What sort of metrics are we going to be able to point to? You gave us one solid one about reducing average wait time from 4 months to 2 weeks or something like that. So that's a solid metric we can say this is a goal we can achieve. And it may be far too soon to ask for numbers, metrics. How are we going to use outcome-based evaluation to say, this is money well spent, so let's continue this funding. Don't let this be short-term, to a rather skeptic public.
Yeah, that's a great question, great point. There's another metric there with the crisis system, for example. So again, short-term, time-limited study in Arizona, they found, if you take a look at the slide, they found a corresponding percentage reduction in the folks that were, helped upstream. So 70% of folks were helped in the community, and then of those, those remainder, about 85 were helped by mobile teams. And so that really, we can actually, and that's what I think actually is actually an advantage of this in terms of it being such a huge problem, is that we have a lot of room for improvement. We know how many folks end up in the ER and in jails that are there almost solely because of mental and behavioral health issues, and we can track and measure a reduction in that, and we can track and measure a corresponding reduction in costs, right? And so we can make the case that if we make these targeted investments right now, we'll actually system-wide see an X amount of return. Now, I'm not a math person, I'm a lawyer, but we're sort of crunching those numbers right now. But you're 100% right, and one thing we are doing, this is why we didn't just, give out grants based on population, because we know, and so with the Community Catalyst Grant Program, for example, we've asked folks to give us their evaluation plan, their metrics, their sustainability plan. And so I think, and we have a lot of really smart and capable folks at the state and in our state universities that we're tapping into to help us with this. Because I can tell you from my previous life in the nonprofit sector, evaluation is a full-time job, and you have to dedicate resources to it. And again, that's the one advantage we have right now, is we can actually dedicate some resources to things you mentioned. So I appreciate that question. You're 100% right. And ultimately, if we can't show concrete, measurable outcomes with our investments, we're not going to get the level of investment we need moving forward.
Chris?
Thank you, Doug. And to follow up on Representative's question or comments, and to reinforce some of the things that Jay has mentioned, is, he talks about on one of these slides the tremendous amount of federal funding that we've received, but it is temporary. It is short term, and so it does allow for pilot programs in government. We're not usually risk takers. This is an interesting opportunity to, I think on the Community Catalyst Grant Program, receiving tremendous amounts of ideas put forward in their grant application process. This is the time to try new things, but we also have to have those metrics and the reality. And it's not so much for next budget session in 2023, but in 2025, a lot of this money is going to expire. It has to be expended by then. This is the time we need to take and look at the results from some of these things that we're trying, because then there's going to be a tough decision when the hundreds of millions of dollars is no longer available. We're back to allocating our scarce resources, and we're going to have to make decisions to hopefully make them based on the facts and the successes, but then also have the reality check on things that we tried but didn't work out, and we have to either recalibrate those programs and try again, or just really direct the resources to those successful programs or the ones with the greatest probability of success.
Yeah. If I could follow up, please. We're always reactive, it seems like, especially when we pass bills and all, rather than proactive, rather than preventative. And it's hard to look ahead and to spend money on prevention when we have these overwhelming existing problems and people in crises. But we have to find a way to make prevention a big part of it. Mr. Hunsinger, a couple years ago, we started tracking physician prescribing of opioids, and that's something that you worked hard on. That certainly is a preventive measure. Outreach programs to kids in high schools, they see graphic things far more than we ever did as children. They're not going to be horrified by the image of a meth addict who looks truly awful. And I don't want to scare people to death, but that's maybe what we need to know, like with the smoking campaign we did for young people. They need to know these are terrible things to do to yourself.
Yeah, absolutely agree.
Any other questions? All right. Thank you, Jay. Next, we're going to get an update on the opioid settlement funds from the Attorney General's office. Corey Voigt is the co-chief counsel of the Complex Litigation Division.
Good Good morning, everyone. Thank you for having me here today. I've spoken to the commission a few times. I'm here to update on the settlements as the director mentioned. This would be slide 2 of Jay's presentation, and this hopefully will be a big source of money to advance some of the initiatives he talked about. I'm always impressed when I come here and I see the minds and the speakers and the questions. It inspires me, and it continues to call me to action in my job and what I've done the last 3.5 years. So with that said, I'm going to give a brief overview of a few of our cases, including the major settlement that has now become has resolved within the last year. So to begin with, we have a lawsuit against Purdue Pharma and also a separate lawsuit against the Sackler family. I want to give a brief update about that. Purdue Pharma filed bankruptcy in September 2019. There was a plan of reorganization that was agreed to that would have provided for funds to come out of the bankruptcy estate. A portion of those funds were to go to the states. At the time, the Sackler family was going to contribute $4.5 billion in return for release from the lawsuits that have been filed against them. That was a bit controversial with some folks. As a result, the plan was appealed. The district court that oversaw the bankruptcy court in New York overturned that plan, and so the plan is not in place at this point. Several people ended up appealing that decision of the district court to the Second Circuit, and the Second Circuit is now considering whether the plan should be in place. Primarily, the issue is whether the Sacklers should be released from liability, a part of the bankruptcy. Or argument was just heard on that matter, I think last week or the week before. I would anticipate a decision in the next 3 to 6 months. And either the decision is going to be the plan is back in place and we'll see settlement dollars flow to the state within the next probably 6 months after that, or they're going to have to go back to the drawing board and come up with another plan, which could take years. So that's Purdue Pharma. That is somewhat of the bad news, so to speak. Now the good news. So we have 2 cases. We had filed a lawsuit against the major distributors, AmerisourceBergen, Cardinal Health, and McKesson, that they distributed opioids throughout the states. And we had a lawsuit against, or we pursued a lawsuit upon settlement to get a consent judgment against Johnson & Johnson. That was a tentative settlement in the fall. You may have heard reports that the overall settlement was $26 billion. That is now not a tentative settlement. It has been resolved. And what that means for Indiana is Indiana filed consent judgments in our actions, and the settlement monies are going to start flowing into Indiana as a result. There was, if you will recall, a bonus structure to these settlements when I talked about this last time, and that bonus structure had to do with if we were able to get all of our litigating subdivisions to join the settlement. And so the General Assembly passed legislation that addressed that issue, but also addressed distribution of the settlement dollars in the 2021 session. There was, I guess, a concern about the manner in which the funds were to be distributed under that legislation. So this past session, the General Assembly amended that legislation and provided for half of the funds to be directly administered by the state through FSSA and half of the funds to go to the local municipalities and counties directly. And so there was a level of control issue there, and there was a lot of stakeholders that were involved in that legislation. AIM, AIC, my office, my boss, the governor's office, and the long and the short of it is that that legislation was passed, and the result, I'm happy to report, as of last week, all our litigating subdivisions have joined the settlement. And all the subdivisions are a part of the settlement under the statutory authority. So what that means for Indiana is that Indiana will see $506 million flow into the state in furtherance of abating this crisis, the opioid crisis, over the next 18 years. Much of that money will be front-loaded, so we're going to see more money in the next 3 to 5 years than over the total 18 years. That money, 70% of it, must go to education, prevention, treatment programs. And those programs can be dedicated to coexisting disorders. So, in sum, we are happy to report that this money will be coming in likely in the next several months. We believe the first distribution will occur at the end of the second quarter, and there will be a second distribution later this year, probably in the third quarter. The state will, and the localities will probably start seeing that money in the fall. And then every July, there's going to be a payment to the state and the localities from there on out over the next 18 or so years. So that's the settlement for Johnson & Johnson and the settlement with the distributors. Lastly, we continue to look at other entities that may have been responsible or had a hand in the crisis. And I know, without specifically discussing those entities or targets, there is one other bankruptcy that may be providing money for abatement within the next several months, and that's the Mallinckrodt bankruptcy. Mallinckrodt is an Irish pharmaceutical company, and they produce generic opioids. They went into bankruptcy within the last year. They have a plan that has been agreed to and has not gone through an appeal process, as I discussed with Purdue Pharma. At one time, and the number may have changed during the plan process, but at one time it was reported about $1.6 billion would go to all the states. Of that, I'd say Indiana will get approximately 2.2%. That's all I have. Thank you for having me. I will take any questions at this point.
Senator
Yes,
Yoder.
Thank you. I just wanted to make sure I heard you correctly, because my elected leaders in Monroe County were wondering, did you say half will go to the state and half will go to local units?
That's correct, sir.
Okay, I just wanted to make sure.
Yeah.
Thank you.
And, excuse me, have you, do the local agencies have guidelines in place for how to apply for this funding?
That's a good question. In fact, they've contacted us. We have been in touch with the State Board of Accounts and then also with the State Budget Agency. And my understanding is that process is being rolled out to them. Of course, we are in touch with AIM and AIC, and they will advise their members on how that is to occur too, but that is in the works.
Okay, thank you.
Dan? Oh. So as the funding relates to the 50% that the state will receive, as that comes from House Bill 1193, which in some ways uncomplicates the way in which it was prescribed for us to distribute the money originally. We're looking at, we're using the Johns Hopkins Bloomberg Public School of Health's 5 guiding principles to ensure that dollars are used most efficiently. And those are 1, to spend money to save lives, 2, to use evidence to guide our spending, and 3, invest in youth prevention, 4, focus on racial equity, and 5, develop a fair and transparent process for where to spend the funds. I also encourage all the local units of government to use these same principles when determining how to spend the funds they'll receive from the settlement as well. So the Family and Social Services Administration, DMHA through Jay and his team, we've been having conversations with stakeholders at the Association of Counties, AIM, the Council for Mental Health Centers, among many others, to determine how we'll distribute some of the state dollars. And currently we are envisioning setting aside funds for a match or incentive program so that when local units of government utilize their dollars in certain ways, we will provide additional funds to support those programs. And then likely our focus areas will be on treatment and recovery infrastructure, workforce, because we can't expand programs and without people. And we're going to focus on prevention, specifically those that are addressing trauma and adverse childhood experiences, and finally harm reduction. Also in the near future, we'll be creating a webpage on the Next Level Recovery website where information and links regarding the settlement disbursement will be posted, and that will be at recovery.in.gov. With that, any questions? Okay. Moving on, we have an update from the Criminal Justice Institute. Michael Ross.
Good afternoon, and thank you, Doug. I'm here on behalf of Executive Director McDonald today, and he sends his apologies for not being here. A couple brief updates from us, but I think they're relevant and important. We undertook a process about 3 years ago to completely overhaul the structure of the local coordinating councils by standardizing, strengthening, and really ensuring that they function in a stable way. And I'm happy to report to everyone that we'd set a goal for the end of the first 3 years for our reporting cycle, which just closed in April, that we'd have 95% of LCCs both functioning and reporting on time with the standardized window that we implemented. And we hit 94% of existing LCCs this year. So we have a total of 92 that could exist. We have 87 that are functioning at the moment. And when you count the additional 2 that are in the process of restarting, we hit 96% for submission. So we now have a standardized calendar. They submit in April. And we're able to then analyze that and look for common themes amongst these complex community organizations. So we are very happy with that. As we move into sort of the next process, and it typically takes about those 3 years for this standardization to occur, we're going to be continuing to look at how we can provide both support to them, but allow them to use their local knowledge and local solutions to really decide how to use those community dollars in the best way possible. So we've established a local coordinating council advisory board from regional hubs throughout the local coordinating councils that will be providing us with recommendations on thematic elements that can be used for all of the buckets, so prevention, education, treatment, intervention, justice services, and support, so that they have thematic areas they can look to fund, as opposed to saying you should fund this item or this item. They can really look for the ingredients that make them successful. We continue to grow the Indiana Coalition Resource Network, which we funded 2 years ago via a pilot project. This year we're hopeful and continue to expand that to bring in additional coalitions to really have that be a network of networks. So coalitions talking to coalitions, peers talking to peers, supporting each other through resources. Finally, we're really excited to bring an end-of-year report. As many of you know, we've really worked hard to standardize a lot of our reporting and also create items like our manual for the LCCs. We've been working on an end-of-year report, and think of it kind of like baseball cards for each one of the counties that will give you a nice summary of what's happening in that coalition and then where their functional level is. We'd hope to have it this month, but we had some staff transition like I think everybody's having. And so we plan to hopefully have it for everybody by the next meeting, and we're really, I think, looking forward to the conversations that we'll be able to foster, and really the sense-making at the qualitative level that we'll be able to undertake moving forward. And at this time, if I have any questions, I'm happy to take them.
Questions? All right. Well, before we adjourn, I just want to go over a handful of numbers that have come out since our last meeting. Shortly after we met in November, the CDC announced that overdose death rates have climbed surpassing 106,000 nationwide for the first time in a 12-month period last November. And this is in line, if you look at the data trends, it's in line with the onset of COVID-19 in 2020 and then the scourge of illicit fentanyl in the market as well. Indiana has accounted for roughly 2,700 of those deaths, and fentanyl is largely the driver here in Indiana. In 85% of overdose deaths, there is fentanyl that shows up in the toxicology screen. So given the overwhelming presence of synthetic opioids in our state, we have continued to emphasize our harm reduction strategies. Through our partnership with Overdose Lifeline, we have distributed over 128,000 doses of naloxone since May of 2020. That's an investment of over $4 million. That also includes our nalox boxes, the 430 that we're placing all around the state, like the one you heard that's out in front of Thrive and Holding Place, and then also our vending machines, which we have placed in high-need, high-traffic areas, jails, emergency departments. There's 19 of those that are being placed statewide. And then in addition, fentanyl test strips are available through our partnership with Overdose Lifeline as well. We have harm reduction teams we have 10 harm reduction teams working statewide to ensure that they're going into high-need areas. They're working to meet Hoosiers where they're at, provide them with the necessary tools and resources they need to stay alive, and also then they're there to provide those connections to help and referrals to treatment. So I want to thank all of you for your time and attention today. As I mentioned before we got started, this is our last meeting under this name, and thanks to Senator Yoder and her legislation, our next meeting of the Indiana Commission to Combat Substance Use Disorder will take place Thursday, August 4th in this room. So thank you. We are adjourned.